Today we will talk about the management of stomas. The word stoma derived from the Greek word for mouth. Stoma is an opening into the bowel through the abdominal wall, and exteriorization of the bowel as either a temporary or permanent measure. Both a small and large bowel can be fashioned into a stoma, depending on the site of disease. And the stoma itself can be an end or a loop of bowel. An end stoma is often permanent, but not at all situations, because the rest of the bowel was removed due to disease, leaving no residual bowel for forming a joint. A joint between bowels is called anastomosis. But sometimes end stoma also may be temporary. A loop stoma is usually temporary and reversible, and can protect the joint and anastomosis, or rest the bowel, allowing disease to dissipate, or a joint to heal completely before reversal is considered. Reversal of stoma. Both types of stoma may be formed in the palliative setting also, when there is extensive disease such as cancer, which may cause an impending obstruction. A large bowel stoma is called colostomy. Is normally situated on the left of the abdomen and produces formed feces, especially if we talk about the sigmoidostoma or distendostoma. The patient wears a closed bag and changes it or void it to evacuate the contents on a regular basis. When we talk about the stoma of small bowel, we call it ileostomy. And the stoma, ileostoma, is usually situated on the right side of the abdomen, and the output varies from a watery fluid to thick liquid effluent, depending on which region of the ileum is exteriorized. In this slide, you may see the examples of stomas. In the first picture, you may see the ileostomy, single barrel stoma, single barrel ileostomy. In the second photo shows a loop transverse colostomy, or double barrel transverse colostomy, including the temporary breaches that may be kept in place for a week or two after construction of the double barrel loop stoma, to provide a healing process and union of tissues in this inverted inside-out position of the bowel, to avoid a retraction of stoma into abdominal cavity, which may cause complications like an irritation and inflammation of surrounding skin. You may see here the proximal stoma opening and the distal stoma opening. In this picture also you may see the double barrel or loop colostomy, and here you may see the single barrel stoma. In this picture you may see typical diseases which can be a cause, an indication for colostomy and ileostomy performing. For example, colostomy usually used patients with bowel cancer, diverticular disease, trauma or Crohn disease, and other conditions that causes colonic obstruction. Ileostomy is usually used in patients with ulcerative colitis, also in case of Crohn disease, obstruction, ischemia of the intestine. For example, in patients with total ulcerative colitis, whole large intestine is removed during the operation, and we will form the ileostomy for passing the intestinal contents. To collect intestinal contents, which are passed from intestinal stomas, patient will use special bags or pouch. There are many types of these pouches. For example, in this slide, you may see that there are transparent pouches for better monitoring of stoma in early postoperative period, and flesh-colored pouches. There are also different types of lock system for emptying of pouches. In this picture, you can see typical pouch which is used in early postoperative period when we should monitor stoma. You can open this bag without removing of the lower part of the bag, which we call pad of the pouch. In next pictures, in these pictures you may see how these pouches are fixed in the abdominal wall. There is a pad that has the specific surface to better adhesion to the skin surrounding the stoma. A regular schedule for changing the pouch before leakage occurs must be established for patients with ileostomy. The patient can be taught to change the pouch. The amount of time a person can keep the appliance, the pouch, sealed to the body surface depends on the location of the stoma and on body structure. The usual wearing time is 5 to 7 days. If we don't talk about the early postoperative period, in early postoperative period, often more frequently. The appliance is emptied every 4 to 6 hours or at the same time the patient empties the bladder. An emptying spout at the bottom of the pouch is closed with a special clip made for this purpose. Most pouches are disposable and odor-proof. Patient can regulate the consistency and odors of the fetus by diet. Foods such as spinach and parsley act as deodorizers in the intestinal tract. Foods that cause odors include cabbage, onions, and fish. Bismuth subcarbonate tablets, which may be prescribed and taken by mouth 3 or 4 times each day, are effective in reducing odor. Thickener, such as diphenxylate, can also be prescribed and taken orally to assist in odor control. In postoperative period, patients should follow a low residue diet for the first 6 to 8 weeks. Strained fruits and vegetables are given. These foods are important source of vitamins A and C. Later, there are few dietary restrictions except for avoiding foods that are high in fiber or hard to digest kernels, such as celery, popcorn, corn, poppy seeds, etc. Foods are reintroduced one at a time. The nurse assesses the patient's tolerance for these foods and reminds him or her to chew food thoroughly. Fluids may be a problem during the summer when fluid lost through perspiration adds to the fluid loss through the ileostomy. Fluids such as Gatorade are helpful in maintaining the electrolyte balance. In the fecal discharge, if the fecal discharge is too watery, fibrous food like whole grain cereals, fresh fruit, skin, beans, corn, nuts are restricted. If the effluent is excessively dry, salt intake is increased. Increased intake of water or fluid does not increase the effluent because excess water is excreted in the urine, not through the bowel. Changing an ileostomy pouch is necessary to prevent leakage. The bag is usually changed every 5 to 7 days. In early postoperative period, often more frequently, to allow for examination of the skin around the stoma and to assist in controlling odor if this becomes a problem. The appliance should be changed at any time that patient complains of burning or itching under the disc or pain in the area of the stoma. Routine changes should be performed early in the morning before breakfast or 2 to 4 hours after a meal when the bowel is least active and discharges are minimal. When we are changing an ostomy appliance or pouch, initially we should promote patient comfort and involvement in the procedure. Have the patient assume a relaxed position, provide privacy, explain details of the procedure, expose the ileostomy area, remove the ileostomy belt if worn. After that, we remove the pouch, have the patient sit on the toilet or on a chair facing the toilet. Patient who prefers to stand should face the toilet. The pouch can be removed by gently pushing the skin away from the adhesive. Clean the skin. Wash the skin gently with a soft cloth moistened with water and mild soap. The patient may prefer to bath before putting on a clean appliance. Rinse and dry the skin thoroughly after cleansing. After that, we should use special skin barriers if the patient has problems with skin in this area or in early postoperative period. And apply the pouch when there is no skin irritation. Remove cover from adherent surface of disposable plastic appliance and apply directly to the skin. Press firmly in place for 30 seconds to ensure adherence. In this picture, you can see a special paste for the better adherence. We place this paste around the stoma, and after it, we will apply the pouch. In some cases, patient may have complications related to the stoma. Common complications include skin irritation, diarrhea, stomal stenosis, urinary calculi, and polylithiasis. Peristomal skin irritation, the most common complication of an ileostomy, results from leakage of effluent. A pouch that does not fit well is often the cause. The nurse or an enterostomal therapist adjusts the pouch and skin barriers are applied. Diarrhea manifested by very irritating effluent that rapidly fills the pouch every hour or sooner can quickly lead to dehydration and electrolyte losses. Supplemental water, sodium, and potassium are administered to prevent hypovolemia and hypokalemia. Antidiarrheal agents are administered. There are pictures of patients with peristomal skin problems. We can use special fluid for skin cleansing in these patients, or special additional barriers and cream for improving the skin's condition. The next part of our today's topic is about urinary stomas or cutaneous urinary diversions. Urinary diversion procedures are performed to divert urine from the bladder to a new exit site, usually through a surgically created opening, stoma, in the skin. And these procedures are primarily performed when a bladder tumor necessitates removal of the entire bladder, cystectomy. In these cases, patient has no the bladder in the postoperative period, for example. Urinary diversion has also been used in managing pelvic malignancy, birth defects, strictures, trauma to ureters and urethra, neurogenic bladder, chronic infection causing severe urethral and renal damage, and intractable and interstitial cystitis, and as a last resort in managing incontinence. In this picture, you can see typical cutaneous urinary diversion. In this case, surgeons has created a special ileal conduit and connect both ureters with with the ileal conduit, which was made from the part of the ileum, and urine will pass outside from opening of this ileal conduit. In some cases, ureters may be placed directly to the skin of the abdominal wall without creating of such conduit. In this case, we call it a direct ureterostomy. Various urine collection appliances are available, and the nurse is instrumental in selecting an appropriate one. The urinary appliance may consist of 1 or 2 pieces and may be disposable, usually used once and discarded, or reusable also. The choice of appliance is determined by the location of the stoma and by patient's normal activity, manual dexterity, visual function, body build, economic resources, and preference. A reusable appliance has a faceplate that is attached to the skin surface with cement or adhesive. Either reusable pouches or disposable pouches may be used with the reusable faceplate. Disposable appliances have the advantage of having a surface that is already prepared for application to the skin and of being lightweight and easy to conceal. A skin barrier must be used to protect the skin from excoriation due to exposure to the urine. Changing the appliance. The patient and family are taught to apply and change the appliance so that they are comfortable carrying out the procedure and can do so proficiently. Ideally, the appliance system is changed before the system leaks and at a time that is convenient for the patient. Many patients find early morning most convenient because the urine output is reduced. A variety of appliances are available. An average collecting appliance lasts 3 to 7 days before leakage occurs. Regardless of the type of appliance used, a skin barrier is essential to protect the skin from irritation and excoriation. The patient is instructed to avoid moisturizing soaps when cleaning the area because they interfere with the adhesion of the pouch. Because the degree to which the stoma protrudes is not the same in all patients, there are various accessories and custom-made appliances to solve individual problems. And managing the ostomy appliance. The patient is instructed to empty the pouch by means of a drain valve when it is 1/3 full, because the weight of the urine will cause the pouch to separate from the skin if filled more. Some patients prefer wearing a leg bag attached with an adapter to the drainage apparatus. To promote uninterrupted sleep, the collecting bottle and tubing, 1 unit, are snapped onto an adapter that connects to the ileal appliance. A small amount of urine is left in the bag when the adapter is attached to prevent the bag from collapsing against itself. The tubing may be threaded down the pajama or pants leg to prevent kinking. The collecting bottle and tubing are rinsed daily with cool water and once a week with a 3-to-1 solution of water and white vinegar.